our operation room. And what's important is a gentle aspiration is when you have yellow fat. Yellow fat aspiration means no blood vessels injured, and in opposite to more aggressive techniques where this all is red. And you also see the fat swims up. Here we have the tumescent solution, and to compare the volumes, we have to talk about this volume, not the whole which is in the bag. And by the tumescence technique, it's possible to infiltrate up to 11 liters, and we have up to 8 liters aspirate. And this is safely possible. Finally, we covered with these bandages, no suture, because we use at the open drainage. And very important, the compression garments after. And this is a typical finding next day, just very little bruising. And that's not, it's always that way. No hematomas. That is the proof for tissue sparing technique. Here also a video. 1 day after liposuction of the lower legs, no edema. Skin is soft, no hematoma. That's state of the art of liposuction, for my opinion. Well, there are 2 techniques in Germany allowed to do for lipedema. It's a power-assisted liposuction, the PAL technique. I prefer, and I showed you, we have here the studies about effectivity for lipedema. And the other technique is a water jet assisted liposuction. It's similar, but there is a water at the tip of the cannula, which spills out the fat cells. The post-operative treatment is as important as the operation itself. That means we recommend manual lymphatic drainage for 3 weeks, 2 or 3 times a week, and compression for at least 4 weeks, even longer as necessary. What means necessary? It means a patient should wear compression as long as there is a postoperative edema. It can be weeks, it can be months, it can be years. It depends on the age, the stage, and obesity. We have a huge range of lipedema patients. We have the young ones, stage 1, and older with stage 3 and obesity, and they all need a different concept and an individual concept. And this concept I showed you was a result of an international conference in Vienna in June 2017, and this is a paper. 40 experts from Europe met and wrote this consensus. Well, what about the results after liposuction? This is a questionnaire we use for our first study. We have the visual analog scale for pain, for example, and we saw that it goes down from 8 to almost 0. And that's the main aim of liposuction. We perform a pain therapy. And here are some results. Well, young women are perfect. There's a good skin retraction, and we have good cosmetic results. In elderly patients, that's more difficult. Retraction techniques as laser or argon plasma can be performed, but this is additional, this is cosmetic. Just some example. Here you see just lipedema of the lower legs, but point 8 on the pain scale, and that means there is no correlation between the stage and the complaints. Patient in stage, she has sometimes more pain than a patient in stage 3. Here, after liposuction of the legs, and you see another effect. Her trunk is slim. She lost weight because she did more sports, more better quality of life, and then it was easier for her to lose weight. This is lymphedema. We diagnose when you see here the positive stemmer sign and edema of the feet. It's also possible to use the technique, but we have a dermatosclerosis. That means fat changes to connective tissue, and that's more difficult to aspirate. The aim here was to give her just back mobility. And we have long-term results by Wilfried Schmeller for 8 years. And when we look at the pain, it goes down, then it slightly goes up. That's why there are still lipedema cells remain. We cannot defat, that's impossible. And that's also not necessary. But these lipedema cells still behave like lipedema cells. So this explains the slight recurrence, but it never reached the level before. Well, we have a new guideline in Germany. The first was published 2005. We have since 4 weeks, a new one is published. And the guideline confirms the criteria for diagnosis. These are disproportion, pain. This is a main criteria. Yeah, lipedema without pain is not lipedema, or then we call it lipohypotrophia. Well, the beginning with hormonal changes in a woman's lifetime, puberty, pregnancy, and menopause. These are critical trigger factors. And now the discussion about edema. Well, when we press our thumb into the lower leg and there is a pitting, a hole, that's a proof for edema. And on the left side, there the tissue is soft. There's no edema. And that can be in early stages in the morning, but during the daytime and summer, in the evening, there is more and more edema visible. So in this case, there should be made a decongestive therapy. Well, in 70%, the arms are involved, and we have different types. And that's a family that shows the genetic predisposition. And to differentiate to lymphedema is easy because just look the stemmer sign and look at the feet. And the lymphatic system is in lipedema patients normal. That's not the problem. Well, that are the stages. It shows also the progress, which cannot be individually predicted. But it's also important that these stages are just considering the silhouette, not the complaints. So in our new German guideline, we recommend to use to not use this staging anymore. We are looking for a more objective scale for naming the complaints. It's very often in combination with obesity that nothing to do with each other, but it has a negative influence. So the recommendation is first losing weight, look what's left, and then liposuction. And of course, we prefer perform liposuction in normal weight than in overweight patients. Even by bariatric interventions. And the BMI is not fair for lipedema patients because it includes the lipedema fat, which can be influenced by patient. So our guideline recommends the waist to height ratio for decide is it more obesity or more lipedema. And we developed a holistic concept based on 6 columns. First column means nutrition. We recommend ketogenetic and Mediterranean nutrition. So high protein, low carb is the concept. For sport, we recommend sport in water because we use the advantage is the sport should be vertically because we have here high pressure, which goes less to the surface. So we have a lymphatic drainage effect. We burn calories 3 times effective than any other sports, and we have not the body weight on the ankles. Compression and manual lymphatic drainage. There is an indication when edema is proven by pitting. So first try to treat by compression. If this doesn't work, we recommend additional manual lymphatic drainage. So compression MLD first is edema therapy, and the second, it can be pain therapy, but not for every patient. That should be a trial. It's 50-50. Some say pain is better, some say pain gets worse. So in the last case, there's no motivation for using it. Well, we have the compression and a bandage, and it's new, this manual adaptive compression for elderly patients. And also the intermittent pneumatic compression, Lymphomat, or I think in the US it's FlexiTouch. Yeah. We recommend also for by the German guideline. But it's important to instruct the patient how to do first manual lymphatic herself to open the lymphatic flow before she slips into the manchette. Well, by the fat pads, we also see orthopedic problems by the X position of the leg. And the last column means psychologic aspects. Young patients suffer sometimes from eating disorders, elderly patients from depression, and our guideline recommends professional support in these cases. And well, when do we do liposuction? I have some patients with 17 years old. This is one example. She had pain, she has psychotherapy, and you can imagine for a young woman what means to have heavy and big legs. And after she was a different person. This is my eldest patient, 76. As long as patient is healthy, it's possible to do the liposuction under tumescent, and because it's very safe. Well, we have in our practice, we see 3 problems. Documentation in our daily work in the office, it's time consuming. The stages are not representing the real complaints. And many patients wait years, sometimes decades before they get a diagnosis. That's why I developed with my daughters, they're IT specialists, we developed an app. It's called LipoCheck. we have the support by the German government. The idea is every woman has a smartphone, and she can make 2 photos, answer a questionnaire, and by AI, which is trained with the data of 3,500 patients of mine, it puts out lipid, is it lipedema or not, or is it suspicious for lipedema? It you get the measures of the leg, shows the areas, and gives a lip Q, which is an objective um, parameter for the complaints. And well, the app can do the diagnostic documentation. It can give recommendations for treatment, guideline conform recommendations, of course. As I'm a member of the guideline, I am one-to-one put it in the app. And we also provide knowledge about recent studies and so on. And my plan is also to integrate a tutorial for doctors. And the patient has the app on the smartphone, and it can be transferred to the dashboard, which is in the IT system of the doctor. So he needs less time for all the documentation and gets guideline confirmed recommendations for treatment. Finally, I thank for all great visitors from all over the world. I'm allowed to share my experience with them, and I think everyone is invited for hospitation, and it's always a pleasure to share our experience, and we can always learn from each other. Thank you so far.
Thank you very much. That was awesome. Thank you. I really appreciate you sharing that. And so I want to move into some questions because if that's okay, and I I want to talk more about the early days. And so from what I've gathered, and I'd like you to share in your words, that it was really these women with lipedema that were they were desperate for help. They had tried compression, they had tried diet, and they had not and they still were having suffering. They were still having pain and so could you share like those first patients and how you got the courage to do this?
Yeah, well, the first patients we treat, I think it was 93 or 94. I remember it was a young woman with a lipedema of the upper leg type, and she had pain. And well, we did already many liposuction for cosmetic reason, the hips and stomach, and we had no experience with the legs. But she was so desperate. She said, "Doctor, do it. I have nothing to lose." And it also only can get better. And well, the patient encouraged us to do the lipo. When we ask other colleagues, especially lymphologists, they say, "No, you damage everything." For them, of course, they saw in their clinics all the catastrophic outcomes, and for them is liposuction the work of devil. Yeah?
Yeah.
But we had already some years experience with cosmetic liposuction, and we saw we don't damage lymphatic vessels. We have never seen secondary lymphedema after liposuction wherever we use. And so our conclusion was, when we don't have these complications with aesthetic? Why do we will have them with lipedema? So we tried first very small areas, but we saw it work. And the patient said it was surprising for us, even after 4 or 5 days. She said, "Doctor, where you treat me, I have no more pain, no more lipedema pain." And well, and then we are encouraged to treat more and more patients, and then well, we saw it works. And some other colleagues in Germany also started this treatment, and they had the same experience. And then we said this must be on a scientific database. And Wilfried Schmeller also worked in Darmstadt, and me. We had the first paper first published the first studies.
Yeah, your abstract at the Paris conference yeah.
That was the very first, yeah.
Yeah. And so so I want to now just like more about this, because I see lymphedema too, and I see lymphedema. I've seen post-traumatic lymphedema, including from after liposuction surgery. And but I personally, using the kind of techniques that basically you started and others have validated, that I've not seen lymphedema in my patients. Uh, and so there has to be precautions. It is different than just cosmetic liposuction. And I was hoping you could share, um, um, well, first about maybe uh, either the precautions or maybe some of the anatomy studies or anything like that that you guys did early on to validate this as safe?
Um, well, we just copied our experience from cosmetic liposuction to the lipedema liposuction. And of course, we studied the lymphatic anatomy of the skin.
Yeah.
As you know, the lymphatic collectors this is the fascia, and this is the skin.
Yeah.
And the big lymphatic vessels are along the fascia, and the capillaries are on the skin, and there are some perforators. And this is a fat between, name it the lipedema fat. And when I have my cannula here, I'm always in the middle, and it's shrinking down the fat layer. I try to get not in contact with the skin and not in contact with the fascia, because well, there are the critical structures, and near the fascia, when I do intumescent local anesthesia, patient may have pain. So the patient give me the alarm signal not to go too close to this dangerous area. And that's the way we perform the treatment.
Yeah. But so you shared with me before, and I hope you share more about when you first started sharing your experiences and your surgery on these lipedema ladies to the lymphologist. Would you mind telling that story?
Uh, it was 15 or 20 years ago, when Uli Herpertz learned lymphatic therapy from Astong. Professor Astong is a pioneer in Germany for lymphology, and two fellows, it's Herpertz and Völdi.
Yeah.
And Uli Herpertz was near my clinic, and he heard about our technique, and he came to my clinic with a patient and was beside me in the room, and I show how I do this. And that was a moment where he was convinced. He saw it works. You only believe what you see with your eyes. And then he invited me to give a presentation for lymphology congress in Bad Hersfeld. And well, I give the presentation, and I show the photo of a lipedema patient and ask the audience, would you do liposuction in this case? No arms go up. And well, then I could give my presentation and show, well, it works. And now it's also scientifically proven.
Yeah. Well, I think you're being kind because I think the reception was not warm in that room. I think you shared with me that you felt like you were going to be asked to leave at one point.
Yeah, that's how time changes.
um, and I mean, there's also, and I don't know, there's Eric Brenner and Hoffman and Baumeister did these studies on the lymphatics, and that we are. I feel I'm a student of lymphatic anatomy, and I feel like I have a lot of respect for that, and how and they showed that they not only those now have been well characterized and well mapped, how these main collectors do go longitudinally, and they tend to the newest studies have shown they tend to parallel the saphenous sheath and the small saphenous sheath, and that they on the fascia as you described, and that they are tolerant to longitudinal stresses, but they can be damaged by
Crossing,
small
crossing.
transverse stresses. Yeah. And so and that is something that needs to be respected. And that's so I really think that the anybody doing this should have a great respect in their lipedema ladies, a great respect for those lymphatic collectors and the longitudinal technique, as you say, not crossing. And I follow the same technique. I actually sometimes I actually will map out exactly where those collectors are preoperatively, just to make sure that I'm not going to damage them when I do the surgery.
In my opinion, Thomas, I also think the tumescent helps. It gives more distance to the dangerous structures.
Yeah. We believe, I mean, so I was a student of Dr. Klein's as well, and we believe the importance of tumescent and actually allowing it to sit in, it causes that the fatty tissue to gel and become semi-liquid so that it can be removed. And unfortunately, some of our colleagues just rush through that process and don't allow this tumescent to work as it was designed to.
Yes, exactly.
And yeah, so so that's kind of I mean, I had a few more questions. I mean, I also was very so I this is now kind of I thank you again for letting me spend time in your clinic, and it was interesting to me because I had also had a discussion with Dr. Sattler, Gerhard Sattler, and he was always telling me how he always went from the hip down to the knee, and how he loved that how it allowed it gets, and that's slightly different than your technique. So every surgeon is slightly different, and I actually follow more of what Dr. Sattler encouraged me to do than yours, just a little bit.
Well, I think every surgeon develops his own technique, but I trained many doctors in liposuction also in my office, and I tell them to make every procedure always the same.
Right.
All the incisions always at the markings are always the same. The incisions always the same place, and to have a standard concept. Um, well, that's, I think, important when we work in one office together. But with every surgeon will develop his own technique. But I think the difference between you, Thomas, and me is so tiny. But the range how liposuction is performed in this word, it's huge.
For sure, for sure. Yeah. And then, those are, now, do you have anything else you'd like to share? Again, I, any,
Any suggestions? Well, um, first, I recommend to follow a holistic concept. To help our patients, it's not just liposuction. That will not work. Of course, we need the correct indication, right technique, and so on. But the postoperative care with compression and MLD and so on is as important as the surgery itself. And well, keep it safe. We don't want to have mega liposuction. Uh, if some tell, well, I do it all in one procedure, that's much too dangerous. And we also set a limit in our German guidelines to avoid these mega liposuctions. Well, this is the message. And well, there is a discussion also, which is a better technique. Is it the power or the water jet technique? Well, the best is in what is best in the surgeon's hand and what has the best experience. We have so far no scientific compare of the outcome of these. Um, well, that's where we wait for.
I want to just amplify a couple things and really tell you, that, the diet, the low refined carb, as you said, the Mediterranean type diet, or the ketogenic. Now, I think either are okay, but emphasizing, because some women really benefit from a fully ketogenic, and some more a Mediterranean, with whole foods and less processed foods, less refined carbohydrates, especially the sugars and the white breads and such. Is very important, because you can't, there is no cure for this lipedema. Our surgery help, but diet and exercise and compression, all are important parts of this holistic approach. And I really feel like, the as you saw, Baumgartner's and long-term things. I feel like to achieve the long-term duration, it has to be married with proper adherence to diet and lifestyle. Um, and
Yes, very important. Yeah.
So, well, we have so many similarities. I thank you again, and I actually thought there was going to be questions, and I can't. Let me see. Unfortunately, I do not see any questions from the YouTube live, so I'm gonna stop our YouTube live, and then I'm gonna stop the recording as well. So let me go ahead and um, and I'm gonna just close that now, and then So thank you again, and I'm gonna do a little housekeeping, and I will we'll stay in touch.
We'll stay in touch, Thomas. Thank you.
Bye bye.